I'm thrilled to be in the studio with today's special guest, Dan Bucci from the American Hospital Association, an association that is very close and dear to Hillsdale Hospital. And Dan, first and foremost, welcome to the podcast. It's great to have you on.
Well, thanks for having me, JJ. I appreciate it.
Absolutely. And you and I have had a history together. We actually were able to be together in California not too long ago and had a conversation about some exciting things that were happening at the American Hospital Association. But man, has a lot changed since then. But before we get into that stuff, why don't you just tell the listeners a little bit about yourself, your background, a little bit about what you do at the American Hospital Association?
Sure, thanks. And yeah, you're right. A lot has happened and look forward to getting into that. But I am the regional executive for Region 5 of the American Hospital Association. And Region 5 is made up of a number of the Great Lakes states, so Ohio, Michigan, Indiana, Illinois, and Wisconsin. And really what my role is as a regional executive is to be the front door to all of the hospitals that are AHA members. Make sure they're connected with AHA, they're benefiting from the value of membership, and one, that we're learning from them, that we're hearing from our members, and that insight and input is guiding the AHA in the steps that they take in Washington and on the ground.
And certainly a lot of issues that we share in common, especially in light of some recent news announcements about Medicaid cuts and some other things, which we'll talk about here in just a minute. But I'm gonna ask you a quiz question here, and I hope I'm not putting you on the spot. But what percentage of hospitals in the country are members of the AHA?
Yeah, great question. So it's the vast majority. So the American Hospital Association has been around since 1898. And, we are the voice of hospitals. And so we've got about, probably close to about 3/4 of the hospitals in the United States as members. And that's everything from nonprofit hospitals to for-profit to children's hospitals and cancer hospitals and things like that. So we represent a big tent, big systems, small independents, rurals, 800 beds to 25 beds.
Yeah, and you're working on issues that are very important to us in rural. I'll talk about rural specifically. Obviously, to your point, you're dealing with major systems with 10,000 employees. But their issues are similar to ours to a certain extent. And I think that's very important. But before we get into really the meat of our discussion today, can you tell us a little fun fact about yourself? Maybe something you've done in your lifetime, somewhere you've been that would really connect with our listeners?
Sure. So a couple of things. One, I cut my teeth in Washington when I was a young pup right out of college or high school. Yeah, college, and left Ohio and went out to D.C. without a job and ended up landing with then Congressman Rob Portman from Ohio. Later became Senator Rob Portman, and that was just a great experience for me. Just a great person to learn from, a great person to work with. And you have a lot of opportunities to do a lot of things at a very young age when you're a staffer in Washington. And ultimately ended up working in the Bush administration for 2 years. So that was a great experience. And I was in Washington at a very crazy time. When I look back at my experience, I went through things like the 2000 election, the Clinton impeachment. I was there for that. I was there for the whole tragedy of 9/11, the anthrax scare. I don't know, people don't really remember that one.
No.
And then
where you had to go through every piece of mail, gloves. They had to go through. I think there was a receiving area in D.C. because I remember a little bit of that.
There was, and that was work from home before work from home was a thing.
Yeah.
And then the last thing was I was there for the DC Sniper, and that was just a surreal experience.
Yeah, we all remember Chief Moose, I think was his name.
That's right.
Television every night talking about the challenges, and so you've seen a lot. You've been around a lot. I had a great opportunity to get to know you through the Michigan Hospital Association, and the work that you're doing there for us. You're, presenting at our meetings, talking a little bit about what your organization is doing. And I'm going to get into the heart of some of those issues. But, today we're going to talk about the role of hospitals as it relates to the relationship in government affairs, because I think it's very important. Many times we think that it should function as a separate department. Others don't even have involvement in government, but that is a lot of where our funding sources come from, so we should have a say in it. And obviously it's impossible to function as a healthcare provider in rural America without being aware of and involved in government affairs. So much of what's happened at the Capitol has an impact on how we do our business each and every day, how we serve our communities. So, I'm excited to let our listeners know that Dan is here to share his perspective and insights as a regional executive at the American Hospital Association. And we'll talk about the current healthcare legislation that's right now gathering a lot of headlines across the country, specific to federal funding, and, of course, what it has to do with rural health and healthcare in general. So, Dan, why don't you give us an overview of what the AHA does in national healthcare advocacy? And then I'm going to ask you a follow-up to that is what relationship between the AHA and governments and then AHA and the hospitals play?
Sure. Well, and you raise very good points, JJ. And, hospitals are so dependent on the government as a major payer with respect to Medicare and Medicaid. So we do need to be at the table. The old cliche, if you're not at the table, you're on the table. Yeah. And that's no more true than it is today.
Agreed.
And the good news for that is that the American Hospital Association has an incredible team in Washington. We're headquartered in Chicago, but our team in D.C. is top-notch. Our advocacy group, our lobbying team is well-respected on the Hill. They are sought after as subject matter experts and key advisors. Rick Pollack, our CEO, is a fixture in Washington and highly respected.
Yes.
So the good news is, we're there. We're the boots on the ground 24/7, and we've got your back. And that's really, that's AHA's main role, is to be the hospital's voice in Washington. It's incredibly helpful when our AHA members are with us and helping us do that work. But that's what our DC team is thinking about 24/7, 365 is what can we do in Washington, in the halls of Congress, within the administration, in the courts, nowadays in the courts, to be that voice for our hospitals.
So, Dan, how does the information, go upstream? So, you represent a region, and we've talked a little bit about that, and you have other regional directors that participate. And when information is brought to you at our level, when I say our level, like the Michigan Hospital Association, we're talking to you about issues. What do you do with that? I mean, you're taking it back. Are you the team? Is there another team that's going to Washington? How does that work?
Yeah, great question. So one of the, and you alluded to this, but one of the great things about my job is I get to work very closely with the state associations in my region. And I'm very fortunate. All 5 in my region are very strong, have great leaders. Brian Peters is at the top of that list, the CEO of the Michigan Health and Hospital Association. He is just fantastic at what he does. He leads his team on behalf of the hospitals in Michigan with excellence in everything they do. He actually sits on the AHA board, so we're very fortunate to have him. So I'm kind of the boots on the ground, listening in on those board discussions, what's going on at the state level, and then you multiply that out, right? There's 9 regions within AHA, so I have 8 colleagues that do the same role that I'm doing across the country.
Sure.
And so we're coordinating all of that intel, getting all of that feedback from people like you, JJ. You're a board member of the Michigan Health and Hospital Association, from those state execs. But we also have a number of committees within the American Hospital Association. We have 9 regional policy boards. So information and policy bubbles up from the bottom up, from the membership up to Chicago and to DC, rather than being deemed down from on high. Hospitals shall do this. It doesn't necessarily work that way. Now, of course, some ideas are generated at the board level and then they're floated down. How would this potentially work for our member hospitals?
Yeah.
But by and large, it's bottom up.
Yeah, and I would say you're great partners. When I think about the word partnership, I really think it's the relationship that AHA plays, not only with the associations, but also I'm a member of the AHA, right? So, I mean, it goes beyond just saying I belong to MHA. It's we work very closely with AHA, whether it's listening to podcasts, attending some of your virtual trainings, going to the AHA conference, which I was recently had the honor of being able to attend. A lot of opportunities to engage and connect. So speaking of that, at our last AHA conference, which was in Texas, the government had just passed, the House of Representatives have just passed something that was very concerning to all of us in the room, a cut to the commerce budget to the tune of $880 billion, that's with a B, billion dollars, which we all know that the majority of that's on the backs of Medicaid. And so this conversation now at the national level, state level, and even individual community level is around Medicaid sustainability. Medicaid cuts, which any hospital that takes a cut is in potential jeopardy of closing services and or the hospital, and that's a true story. Becker's review came out with several great articles. Recently, there's been just a plethora of articles that have highlighted what those cuts would mean to hospital closures. In hundreds are estimated to close if Medicaid takes cuts, and 20 are deemed immediate risk of closure in Michigan by the end of this year if those cuts were to be enacted. If there's an immediate effect, that could be very soon. So, Dan, what the heck is going on with Medicaid? What are we hearing? What are we seeing? What are you doing as an association to help us advocate? What does this mean for the community members, for hospitals, and for patients?
Yeah, great question, and a lot to unpack there, JJ. But you're exactly right. It is very concerning. But I think what we need to do is take a breath and a step back and realize that we're really at the beginning of this process. Yesterday was opening day, thank God. So to use a baseball analogy, I would say it's probably like the top of the second inning.
Okay.
And the budget resolution was passed, but that is basically what the budget resolution is basically a framework. It doesn't contain specific line items and cuts. It's basically a framework. And you're right. What that budget resolution does is it mandates that the Energy and Commerce Committee of the House of Representatives come up with about $800 billion in cuts in areas of their jurisdiction, Medicaid chief among them. And so we've already heard pretty strongly from the Trump administration that they don't want to make any cuts to Social Security. They don't want to make cuts to Medicare. So you're right. What does that leave? That basically leaves Medicaid. So we know that that's out there. And the big question now is, well, how do they come up with that $800 billion? And it's $800 billion over a course of 10 years. So there's a number of ways that they can do that, and a lot of these things have been discussed, and some have been put on the back burner, some more on the front burner. So, for example, they could do what's called a per capita cap, where rather than funding Medicaid on a percentage, they give you X amount of dollars per Medicaid beneficiary in your state, and that's it. And that would be very bad for hospitals. It would be very hard to overcome that hurdle. And that's one that I think is kind of on the back burner. I wouldn't say it's not. I wouldn't tell you it's not going to happen, but I think that is one that they have put on the shelf, so to speak. Another thing that they could do is change the way that they match Medicaid funding. So 10-second summary: Medicaid is a state-federal partnership. The state pays a certain percentage of the Medicaid costs, and the federal government pays another percentage of the Medicaid costs. The federal government could decide to lower the percentage that they match from what the state pays. And they could do that with all Medicaid beneficiaries, or they could perhaps particularly focus on the Medicaid expansion population. Mm-hmm. And that is, a little bit more likely because currently the federal government pays for 90% of the cost of those that are covered under Medicaid expansion, and the state only covers 10%. With the rest of the Medicaid population, it's not quite 50-50, but it's much closer to 50-50. So that would be a major concern. And so bottom line,
because Dan, the shift would be to the states, and in places like Michigan where they operate in deficit, where are you going to get that funding? That becomes the issue.
It would cause a very real challenge to the state budget in all 50 states.
Correct.
And if that's the case, the state is going to have to make a choice. We either reduce the Medicaid rolls, we cover fewer services, and either way, it's not good for hospitals. Then we have more uninsured. We have our bad debt will go up, things like that. So it's a challenge across the board. One thing that I think is most likely, if I had to say this is the most likely thing to occur, is I think they may implement some sort of work requirement. We've seen this in some states, and it really hasn't had much of an impact. But that is one thing. It's popular out there on the streets. If you're an able-bodied Medicaid recipient, you should have some sort of a work requirement. So we're definitely, keeping our eye on that one.
Yeah, and so, Dan, you've been around longer than me in terms of politics, and obviously you've had federal experience far greater than anybody probably even listening to this podcast. Have you ever experienced a time when it was this deep of a cut recommended?
Boy, I'd have to go back to like 94, 95, back in the Contract with America days, when the Republicans took over for the first time in 40 years. They took over the House for the first time in 40 years. Yeah. I was a lowly intern in January of 1995, interning for John Kasich, who was the chairman of the House Budget Committee, later became governor of Ohio, like a lifetime ago. But no, I mean, I would say since then that this is probably the biggest threat that we've seen. Yeah.
And before we jump into a couple other important issues for hospitals, just a follow-up question here. Timing. When we look at this in the grand scheme of, urgent as in it's going to happen next week, to we have months to lobby and to get our message out. We do know that the continuing resolution passed. We do know that funds government up through the end of September. But what happens between now and then with some of these proposals?
Yeah, so it's hard to tell, really. But you're right. We're funded through September, so that's a major win. We've already gotten through 3/4 of this year unscathed, so that's a good thing. But who knows what they're going to do come the end of September, and we've seen it always goes right down to the wire. So I would be surprised if there was any kind of agreement or final legislation before the end of September. But our folks in Washington would be better able to answer that. I don't think anything is going to happen next week, but we need to be prepared and be ready and be telling our story and advocating on behalf of ourselves with our leaders in Washington.
Okay, so that leads me to my final question about Medicaid. So we have listeners across the country. What can they do to become engaged in this conversation? Where can they go? What are the resources available for them to advocate? I mean, some people feel helpless. They don't have connections to their, U.S. representative or senator. What do they do? How do they gain access?
Yeah, so I would go to a number of places. You can go to the AHA website. There's a number of resources there that people can go to, and so that would be the first place. I would say your state hospital association. If you live in Michigan, that is a great source of information. But I would tell people, hospitals need to tell their stories, and a lot of times it's better when the patient tells it, and they speak from firsthand experience. And it's not hard to be an advocate. It's a phone call, it's an email to your member of Congress. They don't seem to be doing many town halls lately, but
Yeah, I think there's a couple that have canceled.
right. But members of Congress are human beings, and you can talk to them, you can talk to their staffs, and really just talk to your friends and family and let them know what's at stake. And Medicaid beneficiaries, they're not this nebulous group out there. They're our friends, they're our neighbors, they're our coworkers, and they're our family members. Yeah. Absolutely. And these are real people with real lives and that need real help.
And the last point I'll raise on that is, the talking points for some political leaders is we're not getting rid of Medicaid, JJ. That's an untruth you're spreading. And they're absolutely right. The Medicaid patient is still going to have their Medicaid card. The problem is the reimbursements are cut so low to the hospitals that those hospitals will eliminate programs or even eliminate their hospitals. You won't have access to health care. That becomes the issue. It's like having a brand new car but no gas in the tank. It looks pretty, just like your Medicaid card. It's going to look pretty in your wallet. But in communities like Hillsdale, where we have no public transportation, the nearest hospital 45 miles away, it's about life and death. It truly is. And so we have to remember the conversations about cuts to hospitals is cuts to care.
Right. Yeah, I couldn't have said it any better than you just did, JJ. And it's absolutely right. And hospitals don't cut services because they want to. Right. That's a worst case last scenario. And there's reasons behind it. I mean, hospitals are grossly under reimbursed for Medicare and Medicaid as we sit here today before any cuts are made. So yeah, you're right. If any cuts are made to Medicaid, hospitals, rural hospitals, certainly, but all hospitals across the country are going to have hard decisions to make.
There is, absolutely. All right, so let's move on to something else. We've had some wins in some other areas. In the state legislature just recently, we had some expansion to coverage in 340B program at the representative level. It has to go over to the House. But 340B, it's an important program to hospitals. Can you give us a little background, what 340B is, and then what you're doing as an association to help protect that?
Sure. So 340B is a program, and it's called 340B because that's where it sits in the United States Code. Title X, Section 340, subsection B. And basically what it does, in a nutshell, is it allows certain hospitals that care for a large portion of the Medicaid population to benefit by purchasing certain pharmaceuticals from the drug companies at a lowered, discounted cost. And hospitals use that savings to basically reinvest in the services that they provide to the community, or direct services to the communities that they serve. And this program is under attack from a number of different angles, and mainly because the pharmaceutical companies don't care for it. They don't like to give their products at a discounted price. Right. Yeah. Simple as that. So we are eternally vigilant on 340B. There's a lot of hospitals where that 340B program makes or breaks their bottom line and allows them to stay open and to keep service lines open. And particularly one issue that we've seen is rather one of the big pharmaceutical companies on their own decided this is no longer going to be a discount program. It is going to be a rebate program. So you, Hillsdale Hospital, you will purchase that drug at full cost, and then you will submit the paperwork in the background to prove that you purchased it, to prove that you gave it to your patient, and then we will decide at a time and place of our choosing to give you a rebate back. Right. So we fought that in the courts and within the Department of Health and Human Services, and got a fairly big win there. The government basically came back with the nuclear option of pharmaceutical company, if you do this, you will no longer be able to participate in the Medicare program. Yeah. So that was a deciding factor.
They got some attention.
That's right. But that case was appealed. So we need to be vigilant on appeal to make sure that the court upholds that decision and that no other pharmaceutical companies try to follow suit and do something like that. Yeah. So that's why I said, we're advocating with the executive branch in Congress and now, when the regulatory agencies and in the courts.
Yeah. A lot of work ahead of you still in this area, and we greatly appreciate it. As a 340B hospital, I want to say thank you for your advocacy, Dan. You and your team that do a great job on behalf of hospitals like Hillsdale. And these programs really create an opportunity for us to at least break even in some of our other areas and or even have a margin. And that is incredible for us to be able to continue to do the work that we need to do and provide for our community for services and medications that they need to be well. So thank you for the work that you do. Believe it or not, man, our time is just flying by, but I do have another question for you. Provider recruitment, it's difficult in rural communities specifically, and I know it's throughout the country, but in rural communities, it's even more of a challenge. And we're hearing more and more conversations about physician recruitment, physician retention, strategies for that. I guess right now, what trends is the AHA been watching in this area, and how can hospital leaders improve their recruitment and to a certain extent their retention efforts from your perspective in today's healthcare landscape?
Yeah, great question. And healthcare is not unlike a number of industries where they're having trouble finding people to fill jobs. And it's from top to bottom. It's at the physician ranks. It's at the nursing ranks. And anything with a tech after it, a rad tech, a surge tech.
We're feeling it.
Yeah. And I don't need to explain it to you. You're feeling it. And you're right. Rural hospitals tend to have it a little more difficulty with that, simply because their catchment area is smaller, and not everybody wants to practice in a rural area. And so, what we have seen a lot of hospitals doing is really using a homegrown approach, right? In focusing on keeping those that they have and keeping their employees happy. And a lot of times it's cultural issues, right? Mm-hmm. It's feeling like you're part of a team, like you're doing something good for the community. And that's very important. We've seen a lot of hospitals going into high schools and junior highs, and even talking to kids about healthcare. You talk to a 7th or 8th grader about healthcare, and they know doctors and they know nurses, right? Right. And I don't want to be a nurse, and I'm not smart enough to be a doctor, so I can't do healthcare. Well, nothing could be further from the truth. There's a number of roles and positions that kids may be interested in. We've seen a lot of hospitals working with local community colleges, and basically, there's one in Michigan that offers kids a job right out of high school, and as long as they get that 2-year certification, the hospital will pay for that, and then they'll have a job. I mean, that what a blessing that is to know. hey, if I just do what I'm supposed to do, I'm going to have a job that's making, a good salary, with some good stability, and be able to provide for myself and my family.
Yeah. And I always love those success stories. We have taken individuals that work the switchboard. We have sent them to their CENA training. They've gone to their RN training. We got them to get their bachelor's degree. They went and became RN, got their FNP. And right now, that particular person who started about 15 years ago is a provider on our behavioral health unit. And she started working in our admitting area. Those are incredible stories. So, one of the questions we talk about recruitment and retention, and last night at my board meeting, I had John Barnes for the Michigan Center for Rural Health really give an overview presentation of the work that they do. But one of the things that we talked about is HPSA shortage areas, and that there's federal funding that comes down to help in rural communities place physicians, loan forgiveness. Are you hearing anything on the Hill about these programs? Are they in jeopardy? Would you anticipate to see any departure of funding for those programs? Because that becomes a concern.
Yeah, I would hope not, and I have not heard that. It doesn't necessarily mean that at one point that won't be, on the table and up for discussion. But you're right. That's the health provider shortage area program is fantastic, and it's great for the hospital because they get someone to fill that open spot, and it's great for the physician because medical school is not an inexpensive proposition nowadays, and that loan forgiveness is key.
It sure is. All right, Dan, one last question is, what are you most excited about in the work ahead for the new year? We're 3 months, almost 4 months into it. What are you specifically excited about to be part of or to advocate for?
Yeah, so what I'm excited about is hospitals are really stepping up and telling their story. And it's difficult for us because, we're not wired that way. We're not wired, we're servants. We do things in healthcare because we care about people. We want to be involved with something that's bigger than ourselves. Mm-hmm. So I think we're not wired and inclined to talk about what we do. And we need to do that. And I think more and more hospitals are doing it. And we should. We've got a great story to tell. Right. We're one of the only industries that's open 24/7, 365, ready to care for anyone, regardless of their ability to pay. And in most towns, the hospital is the largest employer, the engine of that community. It's the focal point. It's the meeting place. And we do really good things, from our small and rural hospitals to our largest systems that are academic medical centers training the next generation of physicians and medical leaders. We need to let people know what we're doing. We need to tell our story and not let somebody else tell it for us. And I'm really excited that more and more folks are doing that. Because that's why I do what I do, because I feel who better to advocate and work for than those that are taking care of our loved ones, and at some point ourselves, right? We're all going to be there at some point, and right. I just take great pride in being a part of that healthcare community.
Dan, it's always a pleasure to have you and to talk with you about issues that are impacting our communities, our states, and our federal government. And I really appreciate your perspective. The great news about, the work that you're doing is it's impacting so many lives that you don't even know the lives that you're touching. You don't know that you're touching the Medicaid patient in Hillsdale County, Michigan, living from paycheck to paycheck, but you are. I just want to congratulate you and thank you. As you lift your voice up, you're lifting our voices up. And one thing that's remarkable about Dan is he never goes on script. He's never reading a script. This is all from the heart. The guy does this, it just flows naturally. You remind me a lot of my good friend Brian Peters. You can talk from the heart. You're very articulate. You know the issues, the stories, and you relate them very understandable. And I really appreciate that about you. And I appreciate your passion. And you could be in any industry right now that probably be a heck of a lot more entertaining and better for you, but you're fighting a good fight, Dan. And I want to thank you for joining us on, this is kind of our inaugural podcast that we just recently relaunched as part of our Rural Health Rising, but now Rural Health Today. And it's just a great pleasure to have you on this podcast and to share, some of the work that you're doing that we all need to get around in our respective communities. So I want to thank you for that work that you do.
Well, thank you, JJ. That really means a lot. And to be compared to Brian Peters in any way, shape, or form is quite an honor, and I would take that any day of the week. But I want to thank you and your team. You guys are the day in, day out, providing that level of care to all of your patients. Again, regardless of the ability to pay. And, my mother was a nurse, and so I grew up around that, and I know how hard she worked. I know how hard your team works. Nurses without nurses, the whole healthcare system crumbles, right? They make the world go round. Yeah. And it's not an easy job. And not just nurses, everyone in that building, they're doing it because they have a calling, and that's very admirable. And I can't thank you and your team enough for doing that. And that goes for, every hospital across the country, right? Everyone is pulling their weight and rowing that boat. So I appreciate it.
Well, thanks, Dan. And we'd like to wrap up with a new closing segment, and we call it Rural Health Recommendations. And for every guest we have on this program, we'll ask them to contribute a recommendation on rural life and rural healthcare. And you've been everywhere, man. You've traveled, you flew into Detroit, you drove to Lansing, you've driven here and there, you've seen some of the most remote areas of our country. And I'm kind of excited to hear what your rural recommendation is. But we're going to ask each member to contribute a recommendation for rural life, for healthcare. It could be a tip for someone new working in healthcare. It could be some sage advice on thriving in a rural setting. And we'll add this recommendation to each of our online guides. But from your perspective, Dan, what is a rural health recommendation that you can give to the listener today that they could use as useful information?
Yeah, so I would say two things. One would be, don't be afraid to toot your own horn and tell your story. And I just talked about that, so I don't need to revisit that. But the other one I think would be is, don't be afraid to innovate. And being stagnant will get you nowhere. And that's the way we've always done it is not a good thing to say in healthcare today. Yeah. Things are constantly changing. And, you don't need radical change, and you don't need to redo your whole process, but you can nibble around the edges and become a little bit more efficient, become a little bit more cost effective, become a little bit more patient friendly. And even if it's just taking a step back and thinking about how you talk to patients, right? Because people in healthcare, they deal with these things day in, day out. It's another language for them. You have a patient come in your doors, they're nervous. They're scared. They don't know how things are going to end up. So, slowing down and explaining things to them a little bit, I think is very helpful and kind-hearted.
Certainly some sage advice. Dan, I look forward to having you back on the podcast in the future. And I will be very hopeful that we can celebrate some victories versus talking about some of this very challenging and at times very depressing topics. But thanks for joining us today. We appreciate your time.
I'll celebrate right with you. Thank you, JJ.
Thank you.